Gotta get the streaming going, guys, before I go live because it's on a delay. Going, guys, before I go live because All right, you're in a proverbial green room if you're watching on YouTube, and we're just about to go live in front of our Zoom audience. All right, have fun, everyone. Thanks so much. Let's do it. All right. Greetings, everyone, and welcome back. This is Eric Glazer, and this is your Bright Spots in Healthcare podcast and webinar series produced by Bright Spots Ventures. We bring leaders together each and every episode to not only inform you, but also unearth bright spots, actual successes at health plans, health systems, and other healthcare organizations around the land. Because our goal is to identify as many of these bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We do this because we firmly believe that this approach of finding a bright spot and cloning it is the most effective strategy to improve healthcare in our lifetime. If you have not yet subscribed to the podcast, Bright Spots in Healthcare, I encourage you to do so right now while you're listening to my introduction. It allows you to get downloaded each week. Bright spots, ideas, and insights from leaders across the industry. We've been doing this show for a long time, and there's a lot of unbelievable content from leaders from across all these great organizations that make up the healthcare system in our country. Bright spots in healthcare, wherever you could find them. And then maybe you'll leave a testimonial like Rich Lieberman, CEO at Cortex, did when he says your programming is more useful than 99.9% of the traditional online content out there. Thank you. That means we got to improve by 0.01%. I'm saying that to my team right now. Our topic today is advancing specialty care and Medicare Advantage, physician-led, AI-enabled. Our partner in crime is Vori Healthcare. They're one of our long-standing partners to the show. They are a nationwide MSK practice with doctor-led care teams driving better outcomes. They help pain reduction and MSK issues through their holistic approach and by creating a personalized treatment plan from the convenience of your own home through a virtual first platform. I'm going to tell you a little bit more about that wonderful organization later on in the show. Also, at 45 minutes past the hour, you're going to get another email from me if you're watching live. And that will be a request to take our feedback form. We choose our topics, improve our format by everything you provide us as far as feedback. So we ask you in advance as a favor to take that survey. And what we've been doing lately, because I'm a pretty good note taker and I'll be taking notes today, I share with everyone who takes the survey a copy of my notes. So if you want some notes, which is definitely better than an AI summary of today's bright spots, I'll send them to you. You just have to take the survey. All right, folks, we know that specialty care has been a opportunity for transformation for a while. And we now have this unique opportunity in our lifetime to bring physician leadership together with AI innovation. So today's all-star panel that you see in front of you, they're going to bring some deep operational and clinical expertise to the table, and we're going to be able to explore where the real progress is being made. So get ready to take notes and get your ideas, juices going. To save time, I'm going to bypass bios as we always do, or introductions. We're going to post their bios in the chat, in the show description of your Zoom application, and we'll put it in the show description of the podcast app as well. All right, let's get going, and let's start in Pittsburgh with Julia McDowell, the Vice President of the AI Center of Excellence at Highmark Health. So, Julia, thank you for being here. And how would you just summarize Highmark's overall innovation strategy and maybe provide an example of the strategy in action to get us started?
Good afternoon. I almost said morning. So thank you so much for having me here today. I think it's important to start that, Highmark's commitment to innovation certainly isn't new. It's been woven into our DNA. We've been strategically leveraging AI for many years, building on a culture that I would consider is anchored in curiosity and this, reimagination of work, and that really empowers our people to lean in and help us find out where AI can best serve not only them but the people that we serve as well. And that culture has really set the stage for us to make the right investments in AI. And it's also helped us to thoughtfully scale in this rapid landscape that we're all seeing right now. For us, we have made a decision to strategically align our AI efforts across the company in support of our mission and our living health strategy, which again is all about reinventing health together for the people that we serve. And for us to do that, we focus our efforts and organize our AI portfolio around three key pillars. We stay in the game, win the game, and change the game. And that framework helps us to ensure that we're prioritizing those efforts and really driving the best impact and the greatest impact across Highmark. Staying in the game is all about focusing on productivity and efficiency. How do we leverage AI to streamline our operations, optimize our workflows, and free up our talented people to focus on the high value work that will truly transform healthcare? And so we're trying to find ways that we can use AI to do more with less so that we can reinvest those resources strategically. Winning the game, on the other hand, is all about differentiation. It's about using AI to offer remarkable personalized health experiences and build customer loyalty, doing things that help set us apart from our competition and continuously inspire innovation. You can consider things like AI-powered customer service solutions that anticipate needs and provide more seamless support, for example, as a way that we're positioning AI in that sort of pillar. And then last, change the game is where we really focus on disruption. That pillar is all about revolutionizing healthcare and shifting consumer behaviors, redefining the industry norms and innovating in ways that maybe were previously not considered imaginable within healthcare. And so that's how we use that strategic framework to, again, kind of organize our portfolio and help us determine where we want to make the big bets on how we're going to transform care through AI.
All right, let me see if I captured all this correctly. So we've aligned the entire AI strategy with your living health strategy, which is the big
Yep.
strategy within the organization. And it's focused on reinventing health for the people that you serve. And you have these three pillars. Staying in the game, which is all about doing more with less and productivity and efficiencies. Winning the game, which is differentiating using AI for personalized, and I think these are your words, remarkable experiences to build loyalty. And then changing the game, which is really like disruption, break it
That's
all down, revolutionizing the healthcare, shifting human behavior, shifting the norms, overall transformation.
That's right.
Super helpful. Okay, I'm going to come back to you in a little bit. I want to come back to this and just build upon everything you just said. I really appreciate that. Let's get a little bit more, a little still strategic, but a little more tactical. I'm going to bring in the Vice President of Operations at HEP, Chuck Palermo. Chuck, how are you guys supporting physicians and patients through AI?
Yeah, so for those of you who've never heard of HAP, we are a regional health plan in Southeast Michigan, about 450,000 members strong, and a wholly owned subsidiary of Henry Ford Health. Henry Ford Health is a large healthcare delivery system in the state of Michigan, and just recently the largest employer in the state. And as a regional health plan, we really pride ourselves on understanding our members' needs within the community. And to that effect, we've been spending a lot of time building and developing what I'll refer to for purposes of this conversation are Consumer 360. And what that is a set of data that is considered a golden record for any particular member. It allows us to gain quick insights about our members in near real time, things like members' communication preferences, tenure with the plan, demographic information, HEDIS care gaps. And for this question, I really want to hone in on the gaps in care because I think it's a great showcase of how we're supporting our physicians and their patients, our members, through AI, particularly in the context of specialty care. So we've begun to leverage AI and data analytics to be able to bring these gaps in care to the forefront, making them part of the Consumer 360 data set. And when these care gaps can include, members who are missing screenings or tests such as mammograms or A1C tests, members who are non-compliant with treatment guidelines, perhaps they have hypertension and overdue for a prescription refill, or members who just have incomplete documentation that otherwise may affect members' quality score in the context of HEDIS. What we're able to do with that information is make it readily available to our call center reps and nurses who may be on a call with a member who happens to have a gap in care. Making that information available allows our CSR, nurses, it allows them to be able to address those gaps in care in real time with the member. And when the message is delivered in real time, it increases the likelihood that that member will take the next step of actually getting that appointment scheduled with their specialist or PCP to close the gap in care. Now, for those of you in the call center world who may be thinking adding yet another to do for an already busy CSR and extending their to-do list or checklist, for, if you will, while they're on a call, could be detrimental to your SLAs. And you're not wrong. But I think that leveraging AI can help with this as well. And I won't spend a lot of time on this because I think it could be a separate topic all of its own. But I think it's relevant in the larger conversation here. And that our first step in this wasn't to identify HEDIS gaps and make them available. Our first step in this was really to use some basic generative AI tools to be able to source documentation from our vast document repository that our CSRs access while taking a call, which can include hundreds of documents, some very lengthy documents. And using technology that leverages natural language processing so that our CSRs are able to interact with an internal chat GPT-like function to source the right reference documents with a few simple inputs. Now, being able to do that took our call center, the time that it takes our call center representatives from searching documentation from an average of about 2 minutes and 8 seconds to about 6 seconds today. So leveraging generative AI to solve for an operational deficiency is what allowed our CSRs to be able to dedicate more time to actually engaging with and servicing our members, including being able to address important concerns like gaps in care. Now, an ideal next step of that program, and where we see that going in the future, ideally the near future, is being able to push those care gap closure messages to members to their preferred channel. As I mentioned, the Consumer 360 includes information on our members like their preferred communication channel. If we can meet them in their channel of preference and be able to push those care gap notifications to them through that omni-channel experience, I think that would even further accelerate the effectiveness of gap closure. And particularly, we're actually here at HAP in the implementation phase of Epic's payer platform. And one logical next step I could see is one of those omni-channel avenues being the patient MyChart. And if we're able to communicate with patients through their provider MyChart and say, you have a gap, you have a care gap here, or it looks like you're, non-compliant with a recommended treatment guideline, we would be able to not only message the member with their care gap, but do so in the app that they can schedule the appointment in directly. So I think that will have a profound impact on how we're able to close gaps, particularly gaps in specialty care in the future.
Okay. So we're calling this, for purposes of this conversation, Consumer 360, and it allows the call center to work with the members to educate them on care gaps in specialty care. So you're IDing consumers who have gaps, you're IDing consumers who are not non-adherent, you're IDing consumers who have incomplete data, and then you're enabling the CSRs. And if I may, I'm going to take Julia and Highmark's stay in the game pillar, because this is what it sounds like. You're enabling the CSRs to be more efficient, do more with less, to meet these SLAs and close gaps in care at the same time. By the way, CSRs, customer service reps, SLAs, service level agreements. For those of you who may not know those acronyms, you all probably should, but just in case. And you're allowing to do both of those things at the same time. So a perfect stay in the game pillar, if I may, Julia. And then we're driving appointments to close those gaps. And hopefully in the near future, we're pushing the messaging to preferred channels. And better yet, if we could just integrate it with MyChart and Epic for communication. Sort of got all of that?
Absolutely.
Good. Hey, by the way, these are the notes you could get when you fill out that survey. It's a little plug. I'm taking great notes right now. I'm honed in. A lot of coffee in me. Folks, Q&A. Definitely, you can help me co-facilitate here, and some of our guests may answer the questions in writing too. But just use the Q&A module so we can best manage it, and we'll post answers to everyone if we're writing them. Rather than not use the chat, just harder for us to organize everything. So, Julia, I'm going to come back to you since I basically plagiarized stuff that you've already said. And how is Highmark, leveraging AI beyond now just the identification part of it, maybe the predictive part, but maybe actually how is it changing how care is being delivered? And let's talk about like the high risk specialty population specifically.
Yeah, I'll continue to focus on the insurance side. For those who may not know, Highmark is a diverse health system. So we do have a provider side of our business too, where we have a lot of ways that we're using AI to improve care. But within the insurance side, I would say that we're moving beyond predictive analytics alone in a variety of different ways. In particular, though, it's just that combination of adding the generative AI on top of what's already happening with the predictive analytics. Most of our more disruptive ideas, I'm going to be transparent in saying, are still in proof of concept phase, so not ready to bring them to the big stage. But something that's in production today and already working is happening within our care management population. And it's actually a nice build on what Chuck was just talking about with the member services team. So within our care case management function, we're using predictive AI to identify the individuals who may become high risk for us. And that's all predictive analytics today, and we call that our member listening system. That helps us to identify and then trigger certain individuals or populations into journeys within our care and case management group. The nurses who are then doing the outreach and talking to those members are helping those members to navigate their care in ways that are personalized for them. And so they're able to use generative AI to do that in creative ways that they couldn't have done before. An example of that could be helping a diabetic patient create a meal plan that is personalized for them. They can do that in minutes while they're talking to the patient, and then send that meal plan to the patient immediately after the call using language that that patient understands. Again, in the past, that would be something that would take hours and might be filled with jargon that the patient wouldn't understand, and therefore lead to challenges with adherence to that plan. And so generative AI is just strengthening the bridge between our care and case managers and the members and patients. And again, that's just one small example to bring that to life for you.
So you're taking your generative AI, putting it on top of your predictive analytics platform, and then say for the care and case managers, you're using the predictive AI in partnership with the generative AI for a follow-up. So folks, let's say who are higher risk, that combination of predictive AI and your generative AI is creating a member listening system. And so someone calls it, it triggers a personalized member journey, and then the care manager is able to follow up and then further use generative AI for creative follow-ups like that personalized meal plan written in plain language.
Sort of. The member listening system is all predictive, and that's what triggers. And then the nurse is using generative AI for those interactions and also just helping with their day-to-day efficiencies as well. We have quite a bit of generative AI showing up in that function today, but that is, like I said, one example of how.
Love it. So real quick, because I want to shift now a little bit into like the next segment of the show, producer speak, and we're going to talk about some of the physician-led initiatives and bring in our physicians on the show today. While we do that, we've got a couple upcoming live episodes happening this summer that we want to make it easy for you, all of you who are attending today, to register, and we'll register you. We'll register you for these on your behalf if you'd like us to. So we've got a show on June 11th. I guess technically that's still spring. In New England, that's still winter. AI adoption for value-based care. It's a private event, so if you're with a health system, you may be eligible. So you could let us know if you want to potentially go to that. And then we've got a July 17th webinar and live recording on how high-performing health systems are leveraging AI and for all kinds of things. And we're going to be doing that on July 17th at 12 o'clock. All right. let's move over to like the physician-led content a little bit and hear a little bit about how physicians are helping lead the charge or support the charge with AI. And I know I'm going to bring in Dr. Mary O'Connor. She's been on the show before. She's the co-founder and chief medical officer at Vori. And I know, Mary, that you guys have co-written an article recently about the promise and pitfalls of using AI in MSK care. So, from a clinical leadership lens, a surgical lens, if you will, what's the one area you think is being overlooked in the AI conversation, especially when it comes to specialty care like orthopedics?
Well, Eric, that is a great question. And I just want to preface that I think, AI is such a super powerful tool that's going to dramatically allow us to advance patient care. And I almost liken it to the discovery of penicillin, which ushered in a whole new way that we could treat patients. But there are areas of concern that we must not overlook. And we need to create a clinical discipline around AI validation. Like, we don't just put drugs or medical devices on the market, right? They have to go through clinical trials or some type of validation. And right now, there's a huge amount of enthusiasm for what AI can do, but my concern is that there's a little less rigor around understanding how and why it does what it does and what might be missed. And I say this because, some of our clinical data is inherently biased, both in who it represents and how it's collected. And so when we're building these AI models on top of that data, we risk reinforcing those biases unless we take deliberate steps to test the assumptions and the output of the model. And we've already seen some unexpected and really well-documented findings. For example, a study out of Emory where they created a radiology imaging model and then subsequently found out that when you give that model a chest x-ray or a CT scan of the chest with no patient demographic information, it could predict with astonishing accuracy the race of the patient, even when the images were pixelated to the point that a human wouldn't be able to say that's a chest x-ray or a CT scan of the chest. And what I think was most astonishing was I spoke to the lead investigator and she couldn't explain why that happened. So these models that teach themselves, maybe teaching themselves things that are not really what we want. Because if that information goes into some kind of risk assessment, are they taking data that really shouldn't be used for risk assessment and somehow incorporating that? So that's why, again, we need to test, we need to challenge assumptions about how the tool actually works. And then before we start applying it to a large number of patients. And so particularly for MSK care and orthopedic care, it's very important because we're seeing tools that are being created around triaging patients for orthopedic surgery consultation, right? Or who should get imaging or who should get surgery. And those things can really matter. Until we create that discipline of validation, we risk letting AI scale faster than our understanding of it. And I think that's a gap that we just can't afford.
Understood. That's a great summary. And rather than go back and bullet point those, Mary, what I'm going to do, you guys, that article is called The Promise and Perils of AI and MSK Care. So I know it's packed with all kinds of data and actual insights around basically the validity discipline that you referenced, almost like treating AI as a clinical trial rather than take the clinical data that's already biased and repeating it through an AI model, challenging those assumptions. It's a really interesting piece. It's easy to read. So people want it, I'll send it to you guys. Why don't we, Morgan, we put up a poll and just people that want it, we'll send it out and we'll do it that way. So if you guys want that piece, you don't have to log in or do anything, just click yes and I'll email it to you after the show. Let's shift away temporarily from like the high AI, high impact AI talk, and just talk right now about pragmatic innovations focusing on specialty care and the shared interests between a provider and a plan. And I want to bring in Dr. Krystal Revai. She is the Associate Chief Medical Officer at Health Alliance in Illinois, not to be confused with HAP. And Dr. Revai, I want you to, like, how are you guys thinking about pragmatic innovations and what you're doing to improve specialty care in your part of the world?
Yeah, thanks. So, we know that prior authorization is a burden, is an administrative burden for both the providers and for the health plans. And we have had a long history of an annual review of our prior authorization process and the codes and the procedures that require prior authorization. And historically, this was an incredibly manual process. It required hours of one person's time to, download all the data, evaluate all the data, meet with the appropriate stakeholders, and it was successful. I mean, we at one point eliminated, based on this review, we eliminated prior authorization for most ultrasound procedures. And you can imagine, very high volume. Most of them are relatively low cost, very high approval rates. And it just became very clear from our data that there was no need to continue to prior authorize those. But this process required one person, many, many hours of time. And when that person moved to a different position within the organization, it became very clear that there wasn't going to be really one person that could take that back over. And so we developed within a program that we have a number of Lean Six Sigma black belts that took this question on. And what they came up with was a decision matrix. We came up with a process that would be much faster, that was not dependent on a single person in order to fully evaluate essentially our entire code list to determine if things that we currently prior authorize needed to continue to be prior authorized, and things that we maybe didn't prior authorize today, was there any value to adding prior authorization for those, procedures or medications, et cetera. And the way we did that is that we came up with a weighted scale matrix. So essentially, there were a number of different properties that we looked at. For example, cost, volume, approval rates, change of volume from year to year. And each one of those was given a weighted score between 1 and 10. And at the end, all of the codes had a final score. And based on a cutoff that we decided, anything above that cutoff was reviewed individually. And now we've brought it down from tens of thousands of codes to maybe 100 codes that we would look at individually to determine if it should be maintained on our prior authorization list or removed. And for example, just in this last year, as we're talking about specialty care, two of the examples that we removed prior authorization for hyperbaric oxygen therapy as an entire, category, because we found again that there was relatively high volume and relatively high approval rates with a consistency from year to year. We can also look at subcategories. For example, we took away a couple of the subcategories around hospital beds. So not as an entire category, but we could tell that there were a couple of codes that really consistently did not need to be on prior authorization. Okay. So this takes away a huge amount of administrative burden from the ordering physicians and also for the health plan, because we are not spending our resources on things that really are unnecessary.
So physician-led in partnership with operations, improving the relationship for the plan and for the specialists who are on the other side of those claims. And you're basically taking a disciplined project management approach, Six Sigma, as you called it, to coding, every code having a weighted number at a predetermined cutoff that allowed you to look at all the codes and even some subcategories in the codes.
Exactly.
It's awesome. I'm going to shift real quickly. We're running a little bit behind time, but I think I'll catch us up. I'm going to bring in back Dr. Mary O'Connor, uh, Chief Medical Officer at Vori. Mary, where do you see, in light of the article and everything you were just talking about, where do you see the most promising opportunities coming back to AI now to support specialists, particularly, I'll let you stay in your sweet spot of MSK, and how is that playing out right now as you see it in your own work?
Eric, that's a great question. And I really think the opportunity is for us to create more space for the things that actually drive better outcomes, which I'll summarize. It's the human connection, it's empathy, and it's shared decision making. And so if we look at AI as helping to offload the routine tasks like tracking home exercises, summarizing charts, that's freeing up our clinicians to focus on what really matters, which is connecting with patients and helping them to make decisions based on their personal preferences and values, which is what shared decision making is. And that's something that I don't think AI can do right now. So if we can use AI to deepen that shared decision making process by helping personalize the risks, benefits, and likely outcomes of a treatment or a lifestyle behavior change, then the AI tool can really help the patient understand a potential future for them. And I'll share a short story. So a few years ago, I chair a national nonprofit called Movement is Life. We're focused on eliminating health disparities, particularly in the musculoskeletal space. And we interviewed a bunch of patients, like a impact group. Because we know if we can get further upstream and we can get individuals to move more, eat healthier, not be overweight or obese, we are going to dramatically lower their risk of MSK conditions. And so we created a tool with experts at Hopkins at the Bloomberg School of Public Health, where we could put in certain information, sex, race, comorbid factors, how severe their knee pain was. We focused on knee pain, their activity level. We even put in education level as a surrogate for income. And we were able to take all kinds of existing public data and create this model that would be able to say to an individual patient, if you adopt lifestyle changes, if you lose weight, increase your level of physical activity, your knee pain will likely decrease to this lower level. Your functional activity will increase. And by the way, you're going to be able to be more productive at work, which could impact your, personal financial responsibility. We were giving the tool away for free. The challenge is that for clinicians to use the tool, it took more time in the interaction. And so as we've thought about how we can revisit this concept, I think it's really looking at how to make some of these tools patient-facing first, so they can kind of do their homework ahead of time and then come into the clinical encounter with the clinician having seen that and the patient having seen that as well, and then have a richer, deeper discussion about, shared decision-making. And so that's the model that we are focused on at Vori, AI that enhances personalization and empowers partnership, not just efficiency, because it's not about replacing the clinician, it's about amplifying what makes the clinician indispensable.
Okay. So you mentioned, so the AI to create more efficiencies, the stay in the game thing that Julia set us up for so nicely. And then as far as like shared decision making and being able to combine human empathy with actual AI and aligning those two, it feels like it's more, Julia, I'll let you comment on it later, but like changing the game. And what you're saying here is that it may make sense to actually think about because the specialists are so busy and we're not getting them to use it, even when you're giving it away through that not-for-profit for them to use, that maybe we need to convert some of these tools to patient-facing so that the patients could use it and get as much information for the specialists as possible. And so that may have the best chance of adoption, at least early on.
Yes, and I think the key element here is for the patient to feel this is really personalized to them. Okay. When a patient comes in and talks to a surgeon about having surgery, joint replacement surgery, like for example, the surgeon quotes general numbers, 1% risk of infection with knee replacement, but that may not be the individual's risk, right? If they're obese, if they're diabetic, they have other risk factors. So like really being able to personalize that story to them, we can do with AI tools, and it will advance our ability to personalize care, advance patient education, and they will be able to make a better informed decision. And that's the key, right? Engaging patients to be partners in their healthcare journey and responsible for their actions relative to their health.
Got it. Perfect. All right. And folks, I mentioned earlier, like Vori is a nationwide specialty medical practice. I'm not going to go into a long commercial here because we try not to be too commercial here, but Dr. O'Connor and a fellow surgeon, they both co-founded this to change how back and joint pain in general is being treated. And they're integrating pragmatic whole person care approaches with AI, and it allows folks to not bounce around the system, generating all kinds of increased costs and generating all kinds of less than optimal outcomes. And they're focused on obviously reducing unnecessary surgeries, prescribing them when necessary, of course. So if you want to just pick their brain and what they're saying with AI and specialty care in general, you may not even be thinking MSK, but you want to take their expertise and transform it to another specialty area and just want to meet with the team. Let me know. I can make an introduction. I know most of them really well. We've been working together for a long time, and they're just good peeps. So I'll have Morgan put up a poll in a second, and we could get that done. I want to come back to Julia McDowell. She's running AI Center of Excellence at Highmark. And Julia, sort of in this, stay in the game and change the game. I know I'm skipping the middle, but like as far as changing the game, you know, you have limited resources. We're doing all kinds of things all over the country right now in this series of pragmatism, like in bright spots. We're doing some stuff about staying in the game with AI. But what have you found to be the most effective way of aligning incentives with your specialists to actually improve costs, control, improve outcomes, control costs, and just actually change the game in Medicare Advantage?
Yeah. And this applies really across all of our lines of business. And Mary, what you were talking about really resonates with me, because at the end of the day, it's all about behavior change. It's behavior change inside the company. It's behavior change with your patients and the community that you serve. And so how do you do that? How do you build trust? It's daunting sometimes, and it's not going to happen overnight. And so within Highmark, we've really used the Center of Excellence, the AI Center of Excellence construct, as a way to organize resources to focus on how might we, really think about that behavior change at scale, at least within the walls of Highmark. That's how we're getting started. We also have tactics underway with, how we're engaging with the people we serve, of course, but I'll focus on our change strategy internally for right now. And incentives is certainly one core tenet, but you also have to think about your talent and training. You have to think about communications and feedback loops and engagement, and how do you build accountability, and also enable safe access to technology so that you can build that AI literacy. And one of the kind of underpinning and most effective strategies that we've deployed in support of that is what we call our AI ambassador program. Our AI ambassadors are nominated by our C-suite to represent their respective area within our company and serve as the they're serving as the AI expert, both in terms of identifying ways that AI can transform, again, in staying in the game, winning the game, and changing the game. They're looking across all dimensions. And they're also prioritizing against our, targeted outcomes. And they're working both within their scope to think about what the workforce needs, what their customers need, in order to drive usage of this technology. So that group really serves as what I would consider to be like the bridge between the strategy and execution, ensuring that we're being innovative, we're deploying this in a way that we feel is ethically sound, and that it's meeting the true needs of both the workforce as well as, again, the people that we serve, all in line with our strategy. Last year, too, through our tactics here, we were able to get alignment with our executives around making sure that all leaders within this company have a goal around bringing value with AI. And so we've established forums and mechanisms to recognize and celebrate those who are doing just that in ways that are supporting our strategy. So again, when it comes to incentives, it isn't always about the dollars and cents. Certainly, right. there is that component to it, and we're doing that through our standard performance process. But many people are driven by or inspired by the sheer recognition that they're doing something differently in support of our goals, and they're making a difference. And we're giving them the outlet to share those stories with our populations.
Great. I want to come back to maybe an output of that whole Center of Excellence process that you just described in a second.
Okay.
We're running a little bit tight on time, so I want to jump right over to Chuck. Chuck Palermo, VP of Operations at HAP. Chuck, what are some of the friction points, right? We just heard of like a really cool process that Highmark's putting in place. But what are some of the friction points that maybe you've already thought of and diffused when it comes to AI adoption and enablement within HAP?
Yeah, so one thing I think we've been, extremely cautious about in leveraging AI here at HAP is using AI to arrive at a definitive decision that should really be clinical in nature. And I think Dr. O'Connor spoke to this a little bit, but I think it's particularly important in the prior authorization space when there's a potential for a denial of services. So leveraging AI where denial of services is a potential outcome, I think is risky. I think that's probably been warned throughout the industry. So that's something we generally stay away from. Now, can it be used as a tool to help summarize and provide the clinician or medical professional who may be reviewing that authorization with summary documentation or quick access to resources to expedite their review? Potentially, but I think even then it gets a little, you want to proceed with caution, right? I kind of equate it to the autonomous vehicle, right? Accidents occur on the road every day. The first accident involving an autonomous vehicle will bring the entire concept of autonomous vehicles into question. I think the same could be true with AI in some respects. I think many of Dr. O'Connor's comments touched on that. And we're seeing a lot of activity in the market, bringing these tools to the forefront, touting the ability to identify additional savings. And that's where I think, plans particularly probably need to proceed with a little bit of caution. So we're taking a bit more of a calculated approach in terms of how we deploy AI in those clinical areas for that reason. Now, as Dr. Revai mentioned, leveraging AI to streamline PA approvals and help determine which services actually need PA going forward, that I think could be a powerful tool in just saving time and resources and ultimately reducing the cost of care. So if it's a service that is historically always approved, or there's AI can help identify the few instances when it's not approved and why, maybe carve those out as the exception or bear the risk and help make those decisions about what you require a prior auth on it and what you don't. And I think that can help overall reduce the cost of care. Another example I'll touch on briefly is oh, I'm sorry.
No, go ahead. Go ahead.
Another example I'll touch on briefly, and won't spend a lot of time on this, but evaluation management or E&M service coding across provider specialties. There's a lot of offerings in the market right now that tout the ability to bring large savings dollars to health plans and being able to identify when E&M codes are upcoded by providers and specialists, and they tout that their solutions are able to downcode those upcodings without need for clinical record review. I think that's another area that that we've proceeded with caution in. We think that we have to make sure that we're having the right clinical inputs in those decisions to ensure that the right decision is being made, and we're not automatically downcoding for the sake of saving a dollar or two. I think it's important that those clinical inputs are gathered and appropriately put into the process. That systemic applying of a down code can create a lot of abrasion within the provider community and could potentially lead to incorrect determinations by AI if the right clinical resources aren't in play.
Got it. Mary, you're a specialist, you work with specialists as part of your job, you work with health plans as part of your job. Can you provide us with a bright spot where there was an AI-enabled care pathway or pathways that help the provider group deliver better outcomes for members? Let's focus, let's say, if you can, on Medicare Advantage, but it could be any LOB.
Happy to. So I'll share a strong example that has come from our work with Select Health, where our AI-enabled motion guide program we use as part of our virtual MSK care model. And these are all Medicare Advantage members. And we know that typically adherence to a home physical therapy program is a major barrier. 70% of people don't follow through. This is especially true for older adults who may face logistical challenges or fear of making their condition worse through exercise, and they need kind of a higher level of guidance and support. So our AI-enabled program addresses those barriers by giving the patient real-time feedback. They can do it on their phone, their laptop, a tablet, and that is the personalized home PT program that our physical therapists give the patient, but the AI program tracks the number of reps, gives them feedback on, should they squat lower or they're not squatting low enough, and they can do all that from the comfort of their home. So this AI-driven coaching helps reassure patients that they're doing things correctly and safely, which I think is particularly helpful for older patients. And we just published actually our clinical results on a consecutive group of 100 of these Medicare Advantage patients that had at least 3 visits with us. 83% improvement in pain, 84 to 86% improvement in physical function. Only 2% required imaging. Imaging is way overutilized in the MSK space. Only 3% needed in-person referral. With the AI-driven motion guide, we've seen 7 out of 8 patients stick to their care plan compared to just 30% in traditional models. And so this is, I think, a really great example of how AI can augment care without replacing the human connection, help clinicians deliver better outcomes, help patients feel safer, more confident, and more supported in every step of their journey.
That is powerful. Great stuff. Love that. Wow, good stuff. I want to now talk about medication a little bit, and I'm going to bring back in Julia, Julia, we were going to talk about some of the results of that incredible ideation process and platform that you have in place. So could you provide an example of something that may have resulted from your process and how you're generating better outcomes and better navigation in general?
Yeah, absolutely. So as I had mentioned, one of the pillars of our change strategy is around access to technology. Last year, we launched an AI portal called Sidekick that gives everyone safe and secure access to generative AI. And that tool now has 17,000 active users with a regular usage rate of around 60%. So people are coming back and using it time after time. One of the coolest stories that I heard from one of our clinicians came toward the end of last year. We have a clinician who goes into the home and does home health care. And she was talking about a gentleman who was, older in age and on over 20 different medications. And he asked her, what are all of these medications and why am I on them? And she was like, okay, well, let me do some research and get back to you. Normally that research would have taken her a couple days. She has to go in and look up every medication, compare it to his chart, figure out how she wants to synthesize that information and return that to him in a way that's easy to understand. However, with Sidekick, which again is a totally safe and secure tool, she was able to drop in the medications, figure out why each of those medications was prescribed, compare it to his chart to ensure that it's accurate in terms of what the descriptions were. and then use Sidekick to create an email to that patient that easily explained all of the medications, why he was prescribed those medications, and how he should be taking those medications, again, in support of what the doctor had prescribed. So again, it's helping to serve as that bridge to help with medication adherence by building greater understanding, using language that the patient can easily understand, but it also saved a ton of time. That clinician did it within like an hour, which again, it would have taken many days. So that's just one example of how giving broad access to a safe and secure tool can allow a person to customize that tool or use that tool in a way that's effective for their job. And again, in support of our patients and our members.
It's good stuff. Let me take, I know I've been rushing through. I think we're kind of back on schedule. So I want to maybe give the audience some love here. I'm going to pick one that I think maybe you're going to be going to be able to address. I'm going to start with you, Julia, because I don't like giving jump balls. They never seem to work. So you could always pass on this one, and then we'll go on. We'll choose Chuck next, and we'll just go down the line. Are any of you guys using analytics such as conversational behavioral intelligence or vocal biomarker insights, i.e., from those CSR conversations? Is everything proprietary, or are you looking at outside providers for those analytics? So, Julia, I'll start with you, then I'll move over to Chuck.
Yeah, and I'm going to say right now, we aren't using those for insights. We are certainly invested in Ambient to help streamline and simplify our interactions and do on-time coaching for our member services agents and our case managers. Those things are in testing right now. We haven't necessarily scaled that just yet. So I'll kind of leave it at that, maybe pass it over to Chuck if he has anything else to add.
Yeah, maybe not to the extent that maybe what I'm sensing the question was really focused at, but I'll say we've used AI in the call center world for sentiment analysis, things of that nature. We're also looking at AI from a purely operational perspective to help address and assess call quality. So literally taking the transcript from the call, being able to leverage AI to look at a quality assurance sort of guide and be able to call out where there's opportunities to improve that call or coaching opportunities for that particular team member. But I don't know that gets to the level that the question was intended to.
Can only do what we do, Chuck. Yeah. One more, and Julia, this could be a quick pass. I think you're in the best position to answer it because it goes back to your last answer. Do you see more of these collaborative practice agreements with integrating of pharmacists in lead interventions in our ecosystem, especially with the AI, or do you see less because maybe AI will support the case manager?
I think there's a ton of opportunity for collaboration. I think that certainly AI can play a role in that, maybe accelerating it, but I think that the opportunity for collaboration certainly exists.
Okay. Let me jump into a final question or two that I had planned here. I want to bring back in Dr. Mary O'Connor. Let's talk about specialty care and fragmentation of care for MA in particular, Mary. Can you share a case where there was a physician-led AI-enabled approach that helps like streamline the consumer journey from diagnosis to treatment? And is there a way that we were able to improve satisfaction and clinical outcomes? Because right now, especially for MA, there's so much fragmentation and jumping over sort of small little, I'll call it valleys that a person has to jump over to keep their care going. So what, and maybe provide us a little bit of an example of that.
Absolutely, Eric. So I'll share a patient story. We love patient stories. And this was a Medicare Advantage member, 68-year-old retired nurse. I'll call her Leanne. And, nurses can be tough patients, right? And she had been dealing with worsening back and ankle pain. She had received an outreach about our program from her health plan, but she didn't act on it right away. She wasn't sure that virtual care was going to be right for her or, what she should do. But so a few weeks later, we reached out to her with a personalized follow-up message from our team, optimizing using AI to basically match her communication preferences and timing. And then she said, okay, I'm going to give it a try. And after that, her care journey was very smooth and coordinated. And she met with our physician and physical therapist in a single session, which has been an innovative game changer for us for complex patients, which we could have a whole nother section on. And they built the care plan for her. She used Motion Guide, again, our AI-enabled exercise tool, to get that real feedback on her form and progress. She felt supported, and she improved her mobility, reduced her pain, and she felt in control of her health again. And here's, I pulled her quote to share, quote, "I'm a retired nurse. I know what good care looks like. And this was it. I felt I was being seen, supported, and guided at my own pace." Whoa. I mean, that's why I'm in this game, to transform care so that we can get this kind of patient and member experience. And so, all right, I'll go back.
No, you could step
points here. So why do we think we believe that shared specialty risk in MSK care can work when it's physician-led and we use AI and we keep it human-centered? Because we know MSK care is one of the largest cost drivers in the Medicare Advantage population. And it's been hard to take risk in this space, largely because attribution has been tricky, right? MSK conditions flare and fade, unlike other diagnoses like cancer, end-stage renal disease. So we've addressed this challenge by identifying defined sets of MSK ICD-10 codes that we'll take risk on. And with AI, we can go even further. Same thing as Julia spoke about, looking at identifying that rising risk population, reaching out, creating personalized care plans, and supporting adherence, I like engagement better, through tech-enabled pathways that improve outcomes. And this is the model that we need to move towards, because it doesn't just control costs, right? It delivers real care to patients in ways that feel seamless, empathetic, and clinically sound to them. And that's what we need to keep focused on. AI supporting seamless, empathetic, and clinically sound care.
That was great. Let's see if I capture all this. Remember, folks, my B+, A- notes come to you if you just take the survey that already is in your inbox. So Plan recommends this program. You have this AI optimization for communication that gets this former nurse engaged in the first place. Then their care journeys coordinated, meet with the MD and the OT, or is it PT, in the same session. AI-enabled exercises for the PT. Results is a really happy customer. I know what good care looks like, and this is it. And then in summary, when you think about that shared specialty care and risk, it can work if physicians lead it. The attribution is tricky, but you could set ICD-10 codes that you could take risk on, and then you could continue to use the AI enablement for engagement. And I'm simplifying things, but like this delivers the real care for the patient, which is empathetic, seamless, and clinically sound.
Exactly. Great job, Eric.
See, these are the notes I take. That's the only thing I'm really gotten good at. All right, this was awesome. I want to thank the four of you for all the prep work and everything you put into preparing for this. I know you're busy. And to everyone listening and watching, we know you're all busy. And so we do not take the hour that you spend with us for granted. We hope that you use the bright spots, the ideas, and the insights shared today to inspire your thinking. Again, if you want to meet Mary O'Connor or any of the Vori folks for follow-up, and you didn't fill out that poll, you can email me directly, eglazer@brightspotsventures.com. We hope today's episode enhanced your company's current approach, or will enhance your company's current approach to improving healthcare for all of us. Each and every week, our team produces this show for all of you. Remember, this is your Bright Spots in Healthcare podcast, everyone. Take care. Right.
Hey.
On time and every